introduce Julie Bynum. Julie is a doctor and she's a chaired professor at the University of Michigan in the internal medicine and the Division of Geriatric and Palliative Medicine. She's also at the Health Policy and Research Geriatric Center and vice chair for faculty affairs at the University of Michigan. I first got to know Julie when she was at Dartmouth, which is one of the places she was trained in addition to Johns Hopkins. And I've been really excited to have, as we grow and build our research portfolio in aging and our portfolio sort of dealing with cognition and dementia, I'm so excited that we get to have Julie here today to talk to us. And the topic of her presentation, her talk, is Accelerating Population Research and Its Impact to Reduce Burden of Alzheimer's Disease. So thank you, Julie, for being here. And we're all looking forward to your talk. Just a reminder to the audience, once we get to Q&A, if you want to put your name in the chat, then I'll call on you just to manage the questions, and you can turn on your video and your volume and ask your question. If you prefer not to do that, you can put your question in the chat and I'll ask the question for you. All right, thanks so much, Julie.
Thank you, Elizabeth. Thank you to everybody who's attending, and I see at least one friendly face from my past. I'm really disappointed not to be there in person with you. Hi, John, because I have so many connections in various sections of your university that it would have been really nice to do this in person, but we'll do the best we can. So thank you, everyone. I am going to share my slides, and I think we'll just dive right in. It's hard to have a friendly conversational talk when we're doing this by Zoom. So please, Elizabeth, or anybody, if you're having trouble hearing me or seeing anything, please let me know. Is that first slide looking good?
Looks good to me.
Great. So this title of this talk is lifted directly from a new center grant that I have here at the University of Michigan. And it's actually also how I got to know Elizabeth and Duncan. They've been funded through our center for a little pilot study, and it's been wonderful to get to know them. So again, thank you for the invitation, and thanks for everybody's coming today. This is just I don't really have any conflicts. I just have grant funding. It's always funny when they want us to list our grant funding as conflicts of interest on everything that we fill out. So I have some specific goals today. I think you're probably a diverse audience with different levels of interest and experience in the field of dementia in particular. So I've tried to give some general concepts that I think are transferable across lots of areas. The first of which is this idea of thinking about, when we're doing population research, the multiple different ways that research might actually lead to change in the community and impact the populations of people we care about. So we're going to talk a little bit about that. Then I'm going to go into some of the important issues around where we are today in the field of Alzheimer's and dementia research in terms of the scientific language and use of communication across fields, which is actually a very important thing for us to do well. I'll then dive into some strengths and weaknesses of various data sources related to that concept of what's the disease construct we're talking about, in hopes that I can get some of you who are not yet in the field interested and open your eyes to some of the things that are out there and available. And then the last thing I'm going to do, I'm just going to introduce a little bit more about the CAP grant, just because it's fun. So I'll do that. So, the first thing you probably all know, I think, that the NIH has been pouring gobs of money into Alzheimer's disease research, really incredible amounts of funding into this field. And it really got kicked off by the 2011 passage of the National Alzheimer's Plan Act. And, you could sort of ask, I think it would be a reasonable question, why do we need to have a national plan related to Alzheimer's disease? Like, why is this different from any other disease, and why now? Like, why suddenly in this last decade there's this huge push to do more and learn more about dementia, a disease we've known a lot about for a long time? I want to try to help us think through that from a population perspective. I'm having a little trouble with advancing the slides. So, I heard you're interested in aging research in general, and I think when we think about population aging, what's really different about health at older age that shift some of our thinking. I will say, declare my lens of this, all of this world is through public health and healthcare. I'm a physician, I'm trained in public health, and I will use a lot of that language and lens, and I hope that can translate into the way you think about the issues of population burden of this disease. But what's really different about aging populations and health, that we've really survived beyond the age of acute illnesses and short-term cures. And what we have is a population of people who have multiple chronic conditions. They have cognitive impairment, they have physical impairment, and that requires a different set of support services, both in the medical and in the social system, for keeping people well living in our communities. So why is dementia different from many of the other common age-related diseases that were in that prior slide? And oftentimes when we talk about why is this a big deal, we often talk about money. Why is that? It seems sort of inhuman and unkind, but it is a translatable construct that can talk across different stakeholders and actually, frankly, speaks to policymakers. Most of our legislation and regulatory frameworks are really about regulation and funding. And so dollars really matter when you're talking about population and population health from that perspective. So there's this important paper that was published in 2013 by Dr. Hurd that talked about the costs of disease and compared dementia to heart disease and cancer disease, two diseases that are highly funded by research and valued, people understand their cost. And he found that the healthcare costs of dementia are actually higher than those two diseases. And then if we think about what the economic costs are of disease, there's obviously the medical treatment and the psychiatric and behavioral treatments of people who have disease, but there's also often other kinds of costs, which you as an audience will really be more familiar with than maybe some of the medical communities. We often talk about productivity loss, like cancer. In the case of cancer, it's early death, right? So all those working years that are lost by somebody dying early, that's less of an issue with dementia, right? This is a late onset disease. But we do have productivity loss because of all the caregiving that goes on, all the family caregivers and others, the sandwich generation, people taking care of their own kids and their parents simultaneously. We also have all of the issues of supervision and safe housing, providing functional supports, spousal supports that really are not so central and inherent to the diseases of heart disease and cancer. So when Dr. Hurd added in all these informal care costs, it's within the range of doubling the cost of this disease because of all of these indirect informal costs of providing support and care. The other big deal is that we have no effective treatments for this disease. Whereas we do have treatments for heart disease, we do have treatments for cancer. We can't cure all of them, but we certainly can treat and manage. We really don't have that. And I'm sure many of you heard all the news about Adelhelm and all the controversy there, which is a whole nother long conversation that we won't have today. But the idea that we can't alter the natural history of this disease is critically important when we think about the population impact of it. So, I say, if we want to lower the impact of this disease on the population, but we don't have a drug to treat or cure it, what are the ways that we can do that? So I go back to my public health frameworks and I think about primary prevention, secondary prevention, and tertiary prevention, where primary prevention is we're taking people who are well and we're changing things to reduce their risk of moving into an at-risk population even. Whereas secondary prevention is taking people who are at risk, maybe they have a genetic proclivity to this disease, and we're doing some sort of intervention to lower their chances that they will actually transition into disease. And then among people who have disease, we want to prevent them from having negative outcomes of things like hospitalizations and undignified death and those kinds of things in the tertiary prevention. And that's really where we start mitigating the effects on the community around the person living with the disease by doing the tertiary prevention activities. So when I first started talking about this at probably a decade ago at a pharmacoeconomics meeting, there was a real strong divide in the field. There were people who were working on cure, people who wanted to treat this disease and cure it. And the funding actually, which was much more limited at the time, seemed to lean toward that. But there's this other segment of the community saying, and we have people living with disease and we need to make this better. The really great thing that's happened with the influx of funding is now we're sort of have the robustness of funding to be able to address all of it. So much of the field is actually directed toward developing biologic treatments to cure this disease, because the idea is if you can even delay its impact, delay its onset by a few years, it's such a late life disease, you'd make an enormous impact on the population. But that's not what I study, and that's not what we're talking about. We're talking about all those other things that are not drugs that can help people reduce the burden of this disease on the population. So this is a figure I came up with to try to help people who aren't from the public health world sort of think about how and when and what we can do to reduce the impact of this disease, dementia, in the absence of a drug-based cure. So we can modify risk factors in the well population. We can do targeted interventions for people who are at risk. And then as people start to get early disease, we start moving into the healthcare and the population health framework, where we're starting to do disease detection. We're trying to work on protecting people from exploitation. We're getting people to plan for their longer term care. These things start to border across different social care systems and medical care systems. As people get further along, we're treating their behaviors, psychotic behaviors. We're doing medical treatment for all their comorbid illness. We're supporting their functional wellness and their caregivers. And then a really important part of this really devastating disease is making that transition to a dignified end of life and support for the family members. So if you think about that and step back a little bit from a population viewpoint, you can think about what levels of intervention you can make. Where can you make an intervention on this disease course? And I put a little asterisk that this picture and sort of model I'm showing you is from an unfunded grant I wrote in 2010. It could be my favorite grant I ever written. Just want you to know, never got funded. So this is my opportunity to share the ideas with people. So I keep using the same ideas, yes, as I move on. So if you're familiar with the public health language that I've just described, primary prevention, secondary, tertiary prevention, it sort of falls along this framework that I have below, persons at risk, early disease, and these negative outcomes. And often when you want to be doing primary prevention or addressing people at risk, you're really doing a population level intervention. As you start to identify people who might be able to maybe do Sudoku or do something, at an individual level to get rid of those are going to be individual interventions. But then making the care of people who live with this disease better, those are often delivery system interventions. And just to give you some ideas, you might think of better childhood education as a way of reducing the burden of this disease 60 years down the road. You might think of reducing toxic exposures in the environment as a way of reducing the burden of this disease, again, down the road. For people who are already having signs and symptoms, better hearing might actually change their course. I just was at Hopkins last week, where the Cochlear Center is all in on studying hearing. Really fascinating, great work around about that. We've all heard about increasing social engagement. Once people have disease, trying to expose them to trying to reduce their exposure to things that we know will affect their cognition, trying to reduce delirium and medications that are bad for them, those kinds of things. So this helps me think about the frameworks of, I can be less nihilistic. Yes, there's no drug to cure this disease, but there are things we can do and we can move forward, and we need to study and advance them. But what I have found, I have recently read a paper by Professor Hunter that came out in the New England Journal. It was called The Relationship Between Public Health and Clinical Medicine. And it really spoke to me because I have for years tried to help people think about what it is you're studying and how that will translate into change for the population. For me, that means I'm a physician who takes care of patients in the healthcare system. I think the healthcare system doesn't do a great job. And even though finance and payment is not the thing that makes my heart sing, I had to work with health economists because it was the payment in the healthcare system that needed to change to improve the care for the people I cared about. So thinking about what the lever is down the road sort of focused my research. So this paper really spoke to me because he was talking about this continuum between public health, delivery systems, and clinical medicine, and how it's all part of a continuum, and they're not separate entities, and they do interact. And it made me think about some of the things we hear in other aspects of healthcare research, where we hear about translational science, bench to bedside, always thinking about what you're doing on the mouse lab and how that will actually have someday some future application in human health. Same thing when people are developing clinical interventions, they're always taught to nowadays to think about implementation. If you develop a great intervention that works in this very specific controlled environment, what happens when it's wild type out in the community and health systems? How are you going to make sure it gets implemented well? So I'm really trying to embrace the idea of thinking about our population research, always with a mind to how would this actually lead to a reduction in the burden of this disease at the population level? What would be a parallel design to these intervention and implementation studies? It's a little bit like thinking up front about how whatever risk factor I'm studying now might be changed ultimately. Who's going to be my stakeholder if I'm going to address toxins in the environment? Is it the EPA I have to convince? It's not going to be the hospital I have to convince. Those kinds of thoughts from the get-go on our study design, I think might help us accelerate the impact of what we do. So just to play this out a little bit more, this is, again, taking that idea of where we can intervene. And if you wanted to use policy as your lever, you wanted to do something in regulation or in funding, who would you be talking to in the government, for example? So, an example of this would be if you're really interested in the risk factors of modifying disease. I don't know if you can see my arrow. You can see that. You're really going to be talking about the public health community, the EPA, and really these impacts, the size of these bars are meant to convey where on the disease course this particular area of policy is going to have its biggest impact. If you're really interested in the issues of exploitation and harms and elder abuse, you're really going to be working in justice and law enforcement. There's a whole important area of who are the people that are delivering the bedside and in-home care. Really important issues related to migrant workforces and young women who are the lowest paid in the community. These are all labor policy issues. So these are all things that affect the life of a person living with dementia and their caregivers, but they're not healthcare. There are these other aspects of policy, and there's different ways to move those levers. A parallel to that is for people who are doing the healthcare system interventions. I try to help people think about, we change things for better or worse. Things change based on how they're paid for. And so we need to understand that. I can't tell you how many of my physician colleagues, once their parents get to age 70, come to me going, oh my God, I didn't know Medicare didn't pay for long-term care, which is shocking to me, right? Absolutely shocking. One needs to understand, where do older adults with this disease live? Yeah, they live in the community. Some live in nursing homes, but an awful lot live in assisted living. And how do we study people who live in those settings? If you're interested in the healthcare system, we have all these, the clinic, the hospital, rehab, and those are all funded through the Medicare system. But if you're interested in the nursing home and long-term care, you're really talking about private pay and Medicaid. And so you're talking to a different stakeholder group. And then, an area where I wish we could get lots and lots of people energized to work on are the community-based services. How do we provide transportation, housing support, Meals on Wheels, and most people don't know where the funding for that comes at all. There's the Older Americans Act. A lot of this comes through philanthropy and local communities, which is kind of extraordinary that we don't have this sort of robust social safety net in any kind of centralized way, other than through the Older Americans Act and the AAAs. So this is all what I've been talking about so far is just the idea, I'm hoping you take away, this disease is important to our population's well-being, not only because of the people it affects, but the specific people who have disease, because of the multi-layered impacts on all the people around them, their caregivers, the health system, and the policy implications as the growth of the population, as the successful aging of the population leads to a growth in the number of people with this disease, and how thinking ahead, thinking about implementation from the beginning in our population research might help us feel less frustrated or help us move things a little forward and understanding how we move these things forward. So I'm going to change gears and talk more now and that second point about the use of language, because I'm hoping I've gotten a couple people at least to say, oh, maybe this is an area I should look at. And then people say, yeah, but okay, what do you mean by dementia? So I'm going, maybe I should have done this first. Like, what is dementia? This slide conveys what I was taught back in the day when I was a medical student. Dementia is an acquired syndrome of decline in memory loss and other cognitive abilities serious enough to interfere with daily life. So it is a clinical syndrome, a general syndrome that, as the figure shows, the earliest symptoms are typically cognitive. Due to their cognitive decline, people start to lose some functional ability, dressing and other issues, safe driving, ability to work. They often, not everybody, but they often develop behavioral problems, which can be aggression, can be psychotic symptoms, a lot of different kinds of things. And very often this disease, a high proportion of people with this disease spend at least some portion of their life in the nursing home. And the time course that we always talked about was over about 10 years. A really important thing is dementia is a clinical syndrome, a general type, caused by many different things. Alzheimer's disease is a type of dementia. It is a specific cause. Vascular dementia is related to strokes, Lewy body. I have been doing a memory clinic for people with early memory decline. And when you break the news of what their diagnosis is, I've had the conversation go both directions. I tell them that they have Alzheimer's disease, and they say, thank God it's not dementia. And then alternatively, I say, this is dementia. And they say, oh, thank goodness it's not Alzheimer's disease. There's a really fundamental lack of understanding of the use of these terms in the lay public. So we have to be thoughtful about that. But there's been some major changes in the conceptualization of this disease. And today we take much more of a life course perspective and think of the full time spectrum of the development of Alzheimer's disease progression. So that figure that I just showed you in today's way of thinking is really just up here in the last 10 years when disease really takes hold. Because as people did clinical trials, they realized that when we treat out here, when people already have established disease, when you give them drugs, it doesn't make any difference. So now people are saying we really need to get much earlier, much earlier. So we've shifted the notion that this disease is something that has precursor stages many, many decades before the disease. And we need the clinical syndrome presents. And we need to be thinking about that in all aspects of how we present the disease. So what's happened is that our disease labels have changed. The way we define diseases have changed, and it's changed, often driven, in my opinion, by technology advancements. So we had this clinical syndrome, which was kind of a loosey-goosey kind of definition, and then a drug was developed. Now we need to have a good, strong definition for enrolling people in clinical trials. And then we came up ways with measuring amyloid and PET scanning of the brain. And so we needed new definitions related to the biomarkers. And now we can measure things in CSF and all sorts of things. So our definitions of the disease keep getting revised over time. So I'm saying all this to really ask you to be cautious and thoughtful. When we talk about this across disciplines, the language gets confused. Be clear about the population you're speaking about. Be clear that cognitive impairment is not the same thing as dementia. Dementia is significant enough to cause functional decline. Dementia is a general term, Alzheimer's is a specific term. And I'll talk a little bit more about this, but what's happened is we've gone from a clinical syndrome in 1984. In 2011, there were two really big changes, making a strong distinction between Alzheimer's as a cause versus other causes, being able to call out Alzheimer's, and also the identification of a precursor state called mild cognitive impairment. And with that, the identification of biomarkers. More recently, we've now separated into saying there's a clinical syndrome, and then there's biologic disease, which can be present 20 years before the clinical syndrome even shows. So those are just markers like things we can find in the fluid around the brain or in the blood or in imaging of the brain that represent risks for Alzheimer's disease to develop later. So this slide highlights that, right? You know, in the early phases, we were doing dementia syndromes. So we needed to measure cognition and function. That's what we measured to define the disease. And there's lots of epidemiologic data sets out there that do this, and they have various strengths and weaknesses. We have data that is regional. We have data that's national and international. Like the Framingham study would be regional. The health and retirement study would be national. And then there's all the branches of the health and retirement study like ELSA and others that make it international. We have studies that measure that are designed to specifically look at cognition, like the CHAP study, which was in Chicago, or ones that are general population studies of aging that also include cognition. That's the MESA study. We have studies that have actual in-person assessment with clinical adjudication of the diagnosis. That's the ADAM study, which is a study of a sub-study of the health and retirement study. And that's as opposed to studies that use standardized instruments like the mini mental status exam or the TICS or various measures to create sort of score-based indicators of status, which would be in the health and retirement study and the National Health and Aging Trends study. Then there's data sets that have self-reported diagnostics and proxy report. You can imagine that I'm a little suspicious when we're saying somebody who has cognitive impairment is going to self-report their diagnosis, but that's also in a lot of our data sets, they say self-reported diagnosis. Once this 2011 period came along, one of the things that really triggered this re-adjudication of diagnoses was the recognition that several of the epidemiologic studies were coming up with very, very different estimates of population prevalence. So Ken Langa's group with the health and retirement study and David Bennett's group in Chicago were getting these very different numbers. And the fundamental reason is they were using different definitions and they were applying the data differently, which I think is just a fascinating lesson to us now. And then the same time, like I said, they started to really identify these precursor syndromes and the biomarkers and distinguishing that from the clinical syndrome. So now we're today where I want to just touch on something that I think is fascinating. We now have this biologically defined Alzheimer's disease. And what they've done is say, you know, amyloid in the brain, tau in the brain, evidence of neurodegeneration, but you don't have to have cognitive impairment, which is the clinical syndrome. So this figure over to the right is all these new disease labels that people are talking about to identify Alzheimer's disease as something separate from Alzheimer's dementia. And the reason they're doing it, there's very well reasoned. They need to have a definitional system to create explanatory models for the biologic origins of the disease, but it makes for all sorts of confusion for those of us who aren't dealing with the biologic models. So I don't want anybody to remember anything that's on this slide other than to know that our neurologist colleagues and pathologists are really digging in deep in some of these details, and it leads to us sometimes using some mixed language. This is, everything that I just said about the biologic definitions is all about Alzheimer's disease. It has nothing to do with the other types of dementia. And that's really important because if you're interested in racial and ethnic disparities, stroke risk is associated with race and the risk of vascular dementia. If you're interested in frontotemporal dementia, that's really affecting younger people in their 50s. So there's getting some clarity, you don't want to make everybody into physicians and neurologists, but at least pausing a moment to make sure that we know who we're talking about. Again, I think a lot of us have a lot of interest nowadays in understanding how our data represents our population. And one of the major criticisms of the biomarker literature is that really African Americans in particular are not represented in that data. So everything that we're learning about biomarkers are in very, not in heterogeneous populations and in volunteer populations. So that's a real challenge to us. So the other type of data I'm going to talk about, this is where I actually get some expertise, is healthcare generated data. So you'll see a lot of studies today that are using Medicare billing data. Healthcare generated data is data that is collected through the delivery of clinical care, like through notes or electronic health records, or for getting payment for that care. So there's lots of different sources today. You can go to Medicare, you can get Medicare Advantage, which is the managed care component. You can get commercial insurance, Medicaid, minimum data set and OASIS are the assessment files for people in nursing homes or in home care. And a lot of people are now using the electronic health record. Few words about that. This is what I use all the time in my research, but there's some really important caveats to keep in mind if you're using this data. It's dependent on care seeking. People who don't come in for care won't appear in this data. It's estimated about 50% of people with dementia are undiagnosed. And there's differential stigma of this disease across different groups. So this is something to keep really in mind. And also all of the vagaries of physician skill, diagnostic coding systems, changing clinical practices get embedded into healthcare generated data. So when you use this, you have to have some humility about what you're really measuring, and clarity about who might be missing. Nowadays, we have this exciting thing where data is being linked together. So we have multiple studies now that have objective cognitive measures that have linked on the claims data. So we have 2 papers under review right now where we are revalidating claims data against objectively measured cognitive status, one in the health and retirement study and one in the RADC, the Rush Alzheimer's disease study group. So this is exciting. There's growing opportunities using EHRs and claims assessments, but those are all new venues. So the bottom line, I think, in addition to being careful about the use of language, is this top line sentence that the data we use determines the disease construct we're actually studying, and vice versa. If you're interested in studying a specific disease construct and you're doing primary data collection, you're going to have to think about what data it will actually take to study the disease construct you want. Because we can use epidemiologic data, which really identifies that clinical syndrome of dementia. We can use healthcare generated data. What that identifies is diagnosed disease. We can use biomarkers, which are really not the clinical syndrome, but risk factors for developing the clinical syndrome. And today there's all these fantastic new non-traditional novel data, things like using handwriting assessment, life space assessments, retinal scans to talk about somebody's risk. So there's lots of new developments that are exciting and potentially confusing to us. So that's why I pulled this slide together. You know, there's so much to be done in this field, in the Alzheimer's space, so much to be done across basic scientists, clinical science, population health scientists. And one of the tricks from my point of view, because I tend to be one of these people who crosses lots of lines, is making sure we're all talking about the same thing, or at least knowing when we're talking about something different. And in the world of population studies, we're also often trying to use 1 or 2 data sources to have multiple purposes. And they're going to be better or worse suited to any particular question. And trying to be thoughtful about those kinds of issues when you're choosing your study population or data. Okay, pause. So what I want to say here is that I just described a whole lot of nuance. And if somebody's just entering this field, I think it's pretty tricky to feel like I can do this well. Even very experienced people doing studies, we're really trying to encourage experienced people to transition some of their work into Alzheimer's where that's appropriate so that we can generate more knowledge. But there's a lot of nuance. So we wrote this center grant with its intention, its overall global intention was to provide an on-ramp for people who are entering population research using secondary data that aims to reduce the burden of dementia. And you know, the the motivating force for me, and people probably don't know, Ken Langa is one of the lead researchers on health and retirement study and led the ADAM study. And, any of us would love to have him be our mentor on our developing research, but there's only one Ken Langa. And so when we were talking about this grant, I said, Ken, I want to give it away. Like, how do we take those nuance and the stuff we're learning and just make it available? You shouldn't have to be at UNC or the University of Michigan to have access to this information. Let's do asynchronous learning. So that's really the focus. So we're doing some fun stuff that I want to share with you in hopes you might find it useful. One is we have a podcast that's really just being launched, coming out sort of every 2 weeks, called Minding Memory. I'm not of the generation of podcasts. I'm afraid I'm a little older than that. So it was my brainchild because I knew it would reach people younger than me. But this has been really fun. And because it's a podcast, it's pretty short and we can get people to be, it's like the conversation you would have with the Jason Karlowishes about Adelhelm, rather than being, getting some of that nuance and other perspective. So this is a tremendous amount of fun. We're getting some positive feedback on this. And we have our CAPRA website has all this sort of information. The other thing we're doing is, again, we're not trying to do, like this is a live seminar. For me, like the complexity of scheduling is too hard. I'm a simple person. So we're calling them mini seminars, because they're only about 20 minutes long. And they are taking sort of available data sources and getting the short version of how you might think about using this in Alzheimer's disease. So Ken Langa talking about the cognitive assessment in health and retirement study. Donovan Mouse talking about the NHAT study. I'll have one that talks about, the introduction to how to use the claims data and what you're really measuring when you're trying to do these studies. So again, trying to make this accessible. The other thing we're doing is creating data products. So my observation of using secondary data is that we all often recreate the wheel. So, for example, if you're using the NHANES, the National Health and Nutrition Examination Survey, there's actually good cognitive measures in there, but it's not obvious how to use them. And so what Matt Davis has done, who's a data scientist, is develop macros that when you're using NHANES that will help you shortcut to getting to the psychometric measures. So you don't have to build it from scratch. You'll have something that's been QC'd and looked at by others and thought about of a reasonable way to put this data together. So we're doing this across multiple not just publicly available data, but secondary data that's available to people. It could be programming macros, it can be finder files. It depends on what the data set is. I have an ulterior motive. In addition to making it easier for people, one of my concerns is that if we're all doing this separately and differently, our results are going to be all over the place just because we're using different methods. So I'm hoping this is a place where when people develop something, they'll be willing, we can host it, we can put it out there, give people the mechanism to cite it so they use your method in an effort to share code. And it's sort of like data resources sharing, but in a way that's a little easier because you can know how to find it. So that's my last slide. And really, I think we'll have some time for questions, but the summary points match my goals. I think when we're designing our studies for population impact, I would hope that we can be really cognizant of the ways in which any information I gather will be ultimately used to improve lives. It sounds so simple, but it's often hard to do that as we're sort of just starting out our careers, and it feels overwhelming. It doesn't mean you have to do it, be the person who does that opposite end of the spectrum, but being thoughtful about how the information I'm creating might be used. I think being knowledgeable as you go into this area about the nuance of the scientific language, being clear about and intentional and how stakeholders will hear what you're saying. I learned IMO from my texting children. So in my opinion, I don't think our field agrees on this very well. I've talked to leaders in the field and they really don't agree on this new biologic marker definition. So, we're not there yet. It's this newish field. We're just moving forward. So being thoughtful and intentional and saying what you're doing rather than what you wish you were doing with your measure, which sometimes happens. This idea that the data sources determine the disease construct you're measuring, and being honest about that. There's a lot to learn, and even subjective memory impairment, that's actually an important construct for us to think about, even if it's not dementia, and even if it's not cognitive impairment, but just be clear what it is. And then, you're not alone in this. There are resources, increasingly more resources to reach out to. If you find yourself trying to start at square one and build, trying to come up with the wheel, think about reaching out. I've shared just one of the P30s that I'm aware of, that I'm involved in, that I, PI, but there's lots of them. And so reach out. So I'm going to stop there and stop sharing my slides and see if anybody has any questions.
Thank you so much, Julie. That was great. And I know that questions will come in. I'm going to start with one, and then maybe ask another depending on what shows up in the chat. So I was really interested in what you said about handwriting and handwriting degeneration. And, I wondered about sort of tracking change over time and trying to make the distinction between sort of normal cognitive decline, increasing frailty, and how one arrives at that determination that it's something more than that, or something that's taking a different pathway than one would expect.
Yeah, that's an interesting question. So you're saying not even just looking at cross-sectionally, but looking at an individual over time,
or people in a study, in a longitudinal study, things like that. Yeah. So you sort of expect some change. That's sort of normal aging to some degree, but how do you know when that slope is not what you think, not what seems normal?
Yeah, I wish I knew the details. This is we could start a curriculum of all the book clubs of all the papers we want to read and learn. So what I do know is, the original nuns studies where they actually had handwriting samples over people's life, differences in that predicted cognitive decline later. So it's not even a longitudinal change. It was differences in writing. The more recent things that I've seen are just this is the confluence of technology and science, coming in, that it's not so much the shape of writing, it's the speed. So they're measuring it on an iPad, and they're measuring the fluency of writing almost. Okay. I don't know if that's the right language to use. But you're right. So when you have a group of people who have arthritis of the hands, they might have tremor from essential tremor or Parkinson's, which part is cognition and which part is, a physical or a different neurologic disorder? That's really tricky stuff. If we were studying 18-year-olds, it wouldn't be quite so tricky, right? So yeah, it's not that I'm suspicious, but I think in my mind right now, these are associations. Right.
It's interesting that it's the fluency. Because that is really a very different thing than the clarity or the or
word content, word choice. Right. You could imagine doing that, a study of so one of my colleagues here, they use NLP, and that is one of the things people look at, complexity of language and that kind of unrecorded voice. There's an incredible number.
What's NLP?
Oh, I'm sorry, natural language processing. Using the computer to sort out what's being said.
Right. Got it.
Yeah. This is where I think there's an explosion of technology, and I'm overwhelmed by it because I get very pragmatic. So how am I going to use that? And how do I know that it's good? and so that's one of the challenges that I find in this field. It's just an absolute explosion.
Great, thank you. Question came in on the chat from Jenny Momkus. Thinking more about measurement, do you think there are certain constructs of cognition that we should focus on in studying the trajectory of cognitive decline? Do you have any recommendations about the most successful ways people have measured those in population studies?
Yeah, great question. So I'm not a neuropsychologist. I work with them. It's one thing. So, well, I would always defer, but I'm working a lot with the group at Rush now. Lisa Barnes, Fran Grodstein is there, and others. And that particular study has very robust in-person cognitive assessments annually over many, many years until death. Really incredibly rich data where they've done a lot of modeling of trajectories and decline. And you're always dealing with level and slope. So I go back to the racial differences that have really confused people in the field. So what I have learned from Lisa and others is that there are population level differences between the African Americans in their studies and the whites, but the slopes aren't different. Right. So the idea that I think that Jenny's raising is it the decline and the rate of decline more than the level of impairment? And I would agree with that. We have a grant that's being submitted next week. Monday, Tuesday. And one of the things, and there's a publication on this on cognitive age, which is from the Rush group, that's trying to sort of standardize the decline measures of what somebody's cognition looks like. And they're sort of calling it sort of cognitive age. But I think the point's really well taken, that the simplistic notion of where you are today on your performance, is that really the important matter, or is it how it's changing over time? Because certainly somebody can have impaired cognitive performance from birth, right? Learning disabilities. We wouldn't call that dementia. It is about change over baseline. But that's hard to measure in our studies.
Yeah, no, that's right. So in a population that we work in Indonesia, we pretty regularly get women performing worse on our tests than men, and there's a couple of places where that's not true. But is that very common across populations?
Is anybody else on the call who wants to answer that? I think the answer is yes. I mean, we see in the US, numeracy is very different, and it probably has its roots in education, right? Different educational levels in the US, at least. I couldn't speak to the Philippines, but if late life cognitive performance is tightly linked to early childhood education, which we think it is, then you can imagine if you have societal differences in the level of education men and women attain, or the kinds of work and cognitive training that they do through their lifetime is different, you might imagine that the outcomes later would be different. And then the question is also, again, level versus decline. Are you able to look at the gender-based differences in decline versus level of performance, which would be very interesting in that population, I think, because you might not see the decline, even at a lower level of performance.
Thanks.
Probably overwhelmed. Have I scared you off of dementia research?
You have made me more interested in it, so thank you.
You know, one thing, does anybody in this group, there's the pragmatic clinical trials, do people get involved in clinical trials at all from your group? There's another grant, I see John's on, I know he might someday, but I don't know if there are others. Why
don't you say something about what that
is? So often when I talk about CAPRA, I also talk about this other grant, the Impact Collaboratory. I took it out here because I didn't think it would be relevant for much of this audience, but the Impact Collaboratory is a well-funded mechanism to support other people to develop clinical pragmatic trials embedded into health systems to address the non-pharmacological management of people living with dementia. So you can imagine caregiver interventions, health system interventions that address worker issues. Those would be what's called a pragmatic trial, because you're not doing it for efficacy, you're doing it in a real world scenario. And, you know, the econometric nudge trials and those kinds of things would all fall in that. So that's just another, if people are interested in that space, I would direct them to the Impact Collaboratory as a place to read and learn what people are doing in the Alzheimer's space. And it's a grant that's entirely based on getting other people started. It's not doing its own science. So another thing I'd love to call people's attention to.
And is that through University of Michigan as well?
So I could show you the slides. I do have the slides, but I'm not going to show you. This is an enormous grant that involves investigators in 60 institutions.
Oh, wow.
So it's MPI'd by Susan Mitchell at Hebrew Senior Life in the Harvard system, and Vince Moore, who's at Brown. But there are 10 cores. It's an enormous initiative funding pilots and demonstration. I'm the data core director. So we're doing some of the natural language processing work and, all sorts of fun things like that. So it's enormous. And probably there's people at your institution. Actually, I know there are people at an institution. Laura Hansen, isn't she with you guys? Yeah, Laura Hansen's the patient-centered outcomes core. So
cool. Yeah, we don't have tons of people doing clinical trials, but it's something I think, well, not the clinical trials, but I mean, what you're describing sounds like something people would come to be interested in potentially. To do some behavioral intervention type things.
Exactly.
Yeah. So what do you see as the sort of likely scenario for developing systems of care as, levels of dementia go up? I mean, do you think that we'll be able to sort of stave off the numbers and keep the needs at a level where we can, take care of people appropriately, or do you see a crisis on the horizon?
I was trying to be uplifting, Elizabeth. Sorry. That's really a downer question. So if you get me talking about policy and politics and the organization of the American healthcare system, what we have is a system that puts medical care, puts its funds and its efforts toward medical care, and social systems get a much, much lower priority. In addition to that, we have funding systems that are completely siloed. We have long-term care completely siloed from acute care, when in fact, these things in the life of a person with dementia, there is no silo. These things blend together. So the fundamental nature of our delivery systems and their funding are not organized for this population of people and their families. In addition, we do not finance the support of people who need functional cognitive supports in the community, whether those are young people with intellectual disabilities. There are systems for that, but I think any family member will tell you these are not robust systems in the United States. So I think it's an uphill challenge, and why I would love for many more people who are in your fields and the economics world to embrace this issue and try to come up with the creative ways, thinking about the levers of making change to address these problems. Because, it is a wonderful success that we are an aging population, right? We have reduced poverty, we've increased education, we've increased nutrition, we actually have treatment for disease, so we live a long time. Therefore, we will have a very high number of people with dementia. It's a disease of success.
Well, that is uplifting. Well done.
I tried really hard. It took me a long time to come up with that, but it is, it is the success of healthy aging, and it's a world problem, as you know. Right?
And
the whole world is aging.
Right. Are there any countries that are doing a better job on the kind of safety net for people with dementia?
Lots of countries now, I haven't looked at the most recent data, but we did one of the slides I showed was from a special issue of Health Affairs a number of years ago. And there was a whole section on national plans. Lots of countries are now doing national plans. Lots of countries fund the social care system fundamentally differently than we do.
Yeah.
right? And that's just enormously different. That just creates a very different context in which to age in our society, whether you have dementia or not. So I think a lot of countries do better. It would be hard for me to call out specific ones. John might know. I'm on the piece.
I think a lot of the European countries actually, I think the one that comes to mind, Sweden or Netherlands, for instance, they have, dementia-based communities where, folks roam around, but they're safe. And I think that's the key element at the end of the day.
It's what's hard too is because I actually did a term abroad looking at health, in health systems. We were in the Netherlands, and that I get conflict in my own mind about that because it's also segregation, right? So because they do that also with young disabled people, that they have communities of young disabled, but we sort of have this notion of integration, and we should be having a society that can integrate everybody. And I get a real sense of, I'm not sure what's right, because I think they're both have strengths, and I'm not sure which is better. So I don't know. It's hard. It's hard, right?
So is an area where sort of cross comparative work would be really interesting.
Absolutely. And I think the NIA is very interested in that.
Yeah, that's the impression. Yeah.
Very, very interested. Hence ELSA and HRS and La Ciudad and all these studies that, study cognition across the world. I think these are really key topics, learning from across the country, across the world.
Great. Well, thank you very much. If there aren't additional questions, I think we'll wrap up with the seminar, and we really appreciate you being here, and we'll get you to CPC for an in-person visit, without the standing up in front of the crowd, although I know you don't mind, but thank you so much. This was just
all right. Thank you, everybody. Have a good day.
Yeah, thanks. You too.
Yeah.